All right, any questions? Okay, so since no one is asking questions, we'll just go over the questions that were sent to us. Okay, so the first question that I see here is it's about lab remount and clinical remount. So the question is, what is a lab remount and what is a clinical remount? And what is the order we do? Angela, do you think you can answer that one?
Yes. So, okay. So for when you reach this stage, it's when your your patient and you and faculty are satisfied with your pre-processed dentures. So first you well, after you have approval from the patient, faculty, everything is ready. You have all the paperwork signed, all the forms ready, payments have been given as well. Okay, you are ready to get to prepare to have your denture processed. So first you are going to make your Facebook jig. And to make this, you're going to use your pre-processed wax rims. Okay, so you will use your pre-processed wax rim to make the Facebook jig. And this is because when your wax rims go to the lab to be processed, there will be changes that happen with the specific location of your teeth. So to simplify a little bit, the Facebook jig, it helps you preserve like the location or like the positioning of your like cast like in the articulator, so you don't lose that. So after that, you will turn in the dentures and then the lab will process them. Then you will get them back. So when you get them back, during that processing stage, you know, there were some changes that happened to like your teeth setup. So that's when you are going to do the lab remount. What this means is that you're going to use your Facebook jig, which you already prepared before processing, and you're going to use it to remount your dentures. So you will use the Facebook jig that you made before, and you will use it to remount your maxillary arch. And then you will also remount your mandibular. So that's why it's a remount, because you're mounting them again. And you're using your Facebook jig in order to conserve the setup that you had before they were processed. And then you, after you did your remount, so you mounted them again in lab, you're going to check like centrics and then excursives. And this will be to make it easier when you are in clinic. And because if you check like centrics and then excursives like in lab, you will save time when you have your clinical appointment and you try the processed dentures and see how they fit in your patient. But when you have that clinical appointment, you still have to double check that the setup is still appropriate, like because now that your patient is there. So that's why you will also check excursives and then like the centric occlusion excursives in the lab and like in clinic. So you will do it before the clinical appointment, and then once you are in clinic, you will do it like again to make sure that your setup is appropriate, even though you had the processing and by the lab.
No, thank you, Angela.
Yeah.
So
Would you like to add something, Don, or maybe something you'd like to elaborate? Or
yeah, sure. So I know this remount stuff is really confusing. I was very confused about it too when I was taking dentures as a D2. I think I only understood as D3, but so so my understanding is, I don't know how Dr. Jewell defines lab remount, but how I understand lab remount is that it's basically to correct for vertical dimension discrepancies that occur after processing. And so you guys actually don't do this in clinic. We only do clinical remount. So lab remount is if after the denture is processed. My understanding is after denture is processed, before the lab technician breaks the denture out of the master cast, before you do that, they just mount it back on, right? And then to see if vertical dimension has changed. Hopefully, you remember the incisal pin position, so you can, bring it back to that previous incisal pin position that you remembered. So that's the lab remount. Before you break the master cast, you put it back on the articulator and bring it down to the previous incisal pin position / the previous vertical dimension. Okay, and then clinical remount is, so after the lab technician, or I don't know, the prosthodontist does the lab remount, they crack the master cast to retrieve the dentures. And now because the master cast is gone, you have no reference to which you can mount the dentures back on, right? So that's why you have the facewell jig. The facewell jig preserves the position of the maxillary denture in relationship to the patient's condylar axis. So you can use a facewell jig to mount the maxilla, and then take a new CR record clinically to mount the mandible, and that's the clinical remount because it's clinical, right? Lab remount is strictly in the lab. You don't need patient to be there. Now, does that make sense? Or is anyone else confused about this? So clinical remount also, there's, I think, two purposes to it. The first purpose is during delivery appointment, after you adjust the intaglio and the peripheries to make it fit really well. Now the intaglio is different than the record base. So the fit is slightly different, right? So that's one error we have to account for. So that's one of the reasons why we do the clinical remount. And number two is we want to verify that the previous CR record is accurate. So we're taking another CR record. So this is kind of like resetting, right? Any errors that we had previously, we reset everything that day by doing a whole new remount. Make sense? Anyone else confused about this still?
But then just clarify. So then lab remount, that is only to account for issues in vertical dimension. So VDO, that's it. And then the other one is what we thought was actually, okay, got it.
Because if you you bring the vertical dimension down, but you don't really do excursives, because you do the excursives with the lab remount, and that might not be entirely accurate compared to the patient when you actually put in the patient. We were just only getting the vertical dimension.
Can I add one thing, Don?
Yeah, of course, feel free.
One way that, well, all of what they said was true, but one other thing I wanted to add that also made it click in my head when it was explained to me was that the purpose of the lab remount is, even though you're doing similar things in both of them, you're accounting for that change in dimension that could have occurred when processing happened. The reason that you do the lab remount is that you can save time when you do the chair remount. The chair remount happens chair side with the patient there. So pretty much the lab remount is to try to account for any large discrepancies or anything that you can fix before you go into chair side time. And the way it was explained to me is chair side time is way more valuable to the clinician in general. So it's just better to have a lab remount. Sometimes I think people, and correct me if I'm wrong, Don, sometimes I think they sometimes skip lab remount and just go in this, just do the remount clinically. And that's possible, but it's just, like I said, to try to save time chair side. So that's just another thing, I think.
Yeah, that's definitely a very good point. But just to clarify one more thing, the saving time part is the vertical dimension part. The mounting of the maxilla using the facial jig, that's still considered part of the clinical remount. Yeah, but you should still do that in lab just to save time. But the lab remount is when the denture is still on the master cast before you break it out of the master cast. You put it back on the articulator just to regain the video. So you don't have to spend time regaining the video during clinic. So save time, yeah.
So do we not touch the occlusion during the lab remount?
You will touch the occlusion a little bit because that's the only way you can bring down the vertical dimension. But you're not going to go crazy with all the excursives because you're going to do that with the clinical remount.
So you do that chair side?
Yeah, on an articulator, yeah.
Okay.
I had another question. I thought that you could mount the maxillary before you get to before you're in the clinic doing the clinic remount. Is that something people usually do? Or when do you do that?
Yeah, you can do that before because you have the Facebook jig. So if you have a proper Facebook jig made, you can remount it right before the appointment, and then you can mount the bottom when you get there.
Okay, thanks.
Okay, well, the next question we had on the forum that people submitted is the process of adjusting tooth positioning when excursives are missing on one side. Yeah, Chris, can you go over this? This is the trial denture part.
And this is the one question I didn't want to answer. I mean, from what I understand, when you're adjusting, when excursive is missing on one side, you'd adjust to where you'd have heavy excursive on the contralateral side, just by reducing the inclines of the cusps. Am I saying that correct, Don?
Yep. So that'll be if you're delivering, but if it's still in wax, you can just change the tooth positioning. So either so you go to one side, and then one side you have all the excursives, and the other side you don't have any. This means it's either on the side that you have excursives, it's too high, or on the side that you don't have excursives, it's too low. It's either or, right? So you determine which is the problem. Questions? These things are a little bit hard to describe because it's better to describe with the articulator. Okay. Well, the next question is, why do we take a protrusive record? So you take a protrusive record so that you can set the condylar inclination. And that allows you to have a more accurate angle of and / pathway of excursives, so you can start adjusting your excursive contacts. Any questions about that?
Can I add, Don, that
Yeah.
not only, I mean, although that is the main point we do it, it's also so that when you do have the denture delivered to the patient, that when they do go into a protrusive position in their mandible, that the denture is already adjusted in so that you can still have that triangular balance. one meaning one in the front and two in the back, so that it doesn't tip out in any way. So although we specifically do it for condylar inclination when we're making it, it's ultimately because we want, when we go in protrusive, to adjust for that.
Yeah, very true. Any questions about this?
Can we quickly go over what appointments you do centric at and protrusive record?
Yeah, so protrusive record, you do it on the trial denture appointment. And you said centric. Centric, you do it on MMR, trial denture, and delivery, because you're doing a clinical remount. So you're actually doing centric relation record 3 times.
And then do you do protrusive again when you deliver the denture?
Yeah, you do. Yeah, because that's the only way you can get an accurate condylar inclination, so that you can do excursive contacts accurately.
Okay, thanks.
Wait, so just to be clear, we do it once during the wax trying, and then once at the delivery.
Actually, you can just do it 1 time, but it's, I guess, better to do it twice, just in case the first time it wasn't very accurate. But technically, you can just do it once during trial denture, because if your first protrusive record was accurate, and your you remember your condylar inclinations and then the bended angles, you can just set it back to that, like how you remembered. So I don't know how they teach, I forgot how they teach it, but I think it was just once, right? Twice is like if you want to be uber accurate.
For sure, thanks.
Or like if you have a patient that very severely class 2 or class 3, that's when the protrusion record is really important, because they tendency to move the jaw forward differently from those who are in class 1. Yeah.
Any questions regarding this? Okay, well, next question is, what landmarks determine the occlusal plane? So the occlusal plane is, I think Dr. Jewell wants you guys to know it as the edge of the incisal edge, maxillary central incisal edge, to middle and distal of the 1/3 of the retromolar pad, which is pretty much similar to the other definition, which is extending to the posterior 1/2 to 2/3 the height of the retromolar pad. So yeah, maxillary incisal edge to the junction of the middle and distal 1/3 of the retromolar pad is what I would remember. Next question is very inappropriate. I don't know why somebody asked this question, so I'm not going to say it. The next question is, what are the points of reference when doing Facebook? So you have 3 points of reference. You have the orbitale, and you have the occlusal surface of the wax rim, and basically the external canal of the ear. And any questions about that? Okay, well, next question is, why can't patients wear their dentures at night? It's because, yeah, exactly, tissues need rest. The person basically answered his or her question. Yeah, the tissues need rest at night so that blood flow can come back. And also it helps delay bone loss versus if you wore it all the time and never took it off. And also remember, before the final impression appointment, at least 24 hours, the patient should not wear any existing denture, because you want to capture all the tissues at rest. Any questions? Okay, so next question is, what is the point of the pumice for remount? Angela, do you want to answer this one? Point of the pumice?
Yeah, it's so you're able to like remove your dentures later.
Yeah, so exactly. So if you don't use pumice, the stone will basically flow all the way into the ridge, fill it up, all the crooks and crannies, and it's not going to come out basically. And also, yeah, because if you don't use pumice, basically the peripheries will dig deep into the stone and it'll basically retain. So you want to use the pumice so that you cover most of the ridge, leave a few millimeters of the peripheries sticking out, so only that much embeds into the stone, so it can be easily removed. Case-based questions with problems with final delivery. I don't know what this means. Oh, like examples of problems? Is that what you're asking?
Problem I see usually with the final delivery is not enough retentions. So if the denture doesn't have enough retentions, what will you do next? Anyone have an answer? So like if the denture is not retentive at all, what area would you check first? And usually what the case following that, like how do you address the problems?
Yeah, there's a lot of ways in which final delivery can be problematic. Retention might be bad, stability might be bad, vertical dimension might be too small, too large. The CR record was inaccurate from the prior CR record was inaccurate. So when you deliver, the patient bites in a completely different way. Yeah, there's a lot of things that can go wrong. Yeah, I don't know if I should go over every single case though. If anyone wants to hear about a specific case, just let me know.
How do you fix retention?
How do you assess retention?
How do you fix it?
Oh,
Like,
well, let's say if it's a mandible, for example. So mandible, a clinically acceptable result, at least from our school, you don't actually have to have suction retention, because technically mandible has the advantage of gravity. At least won't just fall out, right? Whereas maxilla, if there's no suction retention, it can just fall down because of gravity. So mandible, we don't require suction retention. So if you don't have retention in mandible, that's okay. But you definitely need stability of mandible. You don't want it rocking back and forth. You don't want it rotating. You don't want it rocking. When you put your fingers on the posterior region and press down, it should be pretty stable and it shouldn't rock. So that's stability is more important for mandible, less so retention. For top, yeah, you do want suction retention. And if you're having problems with that, so when you first deliver the denture, you're gonna first check the fit by using PIP paste for the intaglio and also disclosing wax for the peripheries. So you do that, especially though when you adjust peripheries, you want to make sure that you don't end up adjusting too aggressively, too quickly, because that can actually lead to a loss of retention. So keeping that in mind. But if the maxilla just has no retention, the next best solution I can think of is doing a soft reline, or a hard reline if it's really off. Hard reline is basically cutting back the intaglio to create some space, and then taking a new impression, more accurate impression, final impression, and then using that new master cast to fill in that space between the denture and the master cast with new acrylic. So basically rebasing the intaglio so it's more accurate. And it's basically like a permanent solution. Soft reline, you can just do chair side real fast with viscogel. It's kind of like soft, but it needs to be replaced every, I don't know, a couple months because it distorts over time. So those are some ways to deal with retention. Of course, if patients really unsatisfied with the mandible, then you can get implants from overdenture too. Does that answer your question?
Oh, I'll add to John's. There are things that you can check. Usually people doesn't have enough retentions. If they happen with the maxillary, usually is because they didn't bore the mold and the final impression doesn't capture depth of the vestibule. People usually miss the buccal vestibule at the heminola notch. Usually they didn't bore the mold enough, or sometimes they didn't go to the height of the border molding, so it's short over there. Or sometimes it just they didn't carve the posterior palatal seal deep enough, and the posterior palatal seal doesn't provide the seal that we need. You can try to confirm this after you try it in the patient's mouth by looking clinically. Also, you can try to bore the mold again. You can try bore the mold again with the pink compounds to see if you can improve on the suctions and the peripheral seal of your dentures. If it does improve, then it's meaning that you didn't do the border mold and the final impression correctly, and it needs more to add at the vestibule. Sometimes they can do that they can add the border mold again with the new dentures that you just made, and also take the final impressions again and send it back to the lab for a lab remount, a lab reline. Or sometimes if it's the posterior palatal seal and then the intactile is not correctly captured, we can do the soft relines, let the patients wear that for about 2 to 3 days, and then the patient comes back and you take the impression so when they comes back, the denture is actually your impressions. It's called the functional impressions, and then you send it to the lab so that the lab can do the reline based on that as well.
That's a very good point. Thank you for that. Did that answer your question, Melanie?
Yes, thank you.
Okay. Okay, so next question that we got was, is more retromylohyoid space the better? More retromylohyoid. You don't want so much space there. Why would you want so much space there? You're gonna have like a hollow space between the denture and the tissue. The only tolerable amount of space I would say is if the retromylohyoid space, because that area is like kind of often down undercut sometimes, right, towards the inside of the mandible. So sometimes if it's too undercut, the patient might have issues taking the denture in and out because of the undercut. It might cause some trauma to the tissue. So if that's the case, then I would say some space is necessary, but just enough so that patient can take it in and out. You don't want so much space in any area of the denture. So yeah. Any questions about that?
I do. Hi, I was wondering that is the throat choker good or bad in regards for retention and stability?
Throat choker, what is that? I'm not sure what that is.
It's like if you have too much retromylohyoid space, and then the lingual part, the lingual flange of the denture will extend, and then it create like a choker-like thing.
Oh. So you're basically talking about a very long lingual flange around the retromylohyoid area?
Yeah, is that good or bad?
It depends. So the lingual flange, actually any flange, the length of that is determined by functional borders, which means these are not the borders at rest, like the vestibules and the lingual vestibules too. These are the borders that are, these are the borders when the patient is, eating, moving around, smiling, puckering, moving his or her tongue, like in function, right? Because the border during function is different from border during rest. So that's how that will determine the length of the lingual flange. It's not necessarily longer is better or shorter is better. But if I had to choose, probably shorter is better if I had to choose, because longer, if it's overextended, the moment the patient moves the tongue, it's just kind of dislodge. So if I had to choose, shorter would be better. But yeah, did that answer your question?
Thank you.
Any other question about that or anything? Okay, well, if not, we'll move on to the next question that we got here. Can you go through the laboratory remount and Facebook transfer jig? When do you, okay, so we already answered this already. So in clinic, you're not going to do in here at least, clinic, you're not going to do a lab remount because your dentures will already come broken from the master cast. So that already, you can't do the lab remount. So when you get that back, you're going to do part of the clinical remount in the lab ahead of time, which is the maxilla. So you're going to mount the maxilla using the Facebook jig that the lab provides you with. And then after you mount that, you're going to make a plaster cast of the mandible, but you're not going to mount it. You're just going to make little cake of little cast, okay, for the mandible. And then later on in clinic, you're going to put the mandible on that little cast and then fill the space between that and the mounting cookie to mount the mandible. This all of this is meant to just save you chair time. Any question about that part? Okay, so the next question we got is when we make the lab remount to correct OVD and RV, you don't correct RVD. RVD is physiologic rest position of a patient. It's on a patient, so you can't really mess with RVD on an articulator. You can only mess with OVD on an articulator. So lab remount will correct for OVD. Yeah. What do we use to mount the casts? Oh yeah, so everybody went over this. The lab remount, you're gonna have the master cast that you can use to mount. Yeah. So I think we pretty much answered that question already. Okay, the next question is, what is a pressure pot when hydrating dentures? Pressure pot is what you use when you process dentures. When you're curing the acrylic, you put it in a pressure pot, it's hot and pressurized. It allows it to cure quicker. But I don't know if it's used to just hydrate dentures. I don't know.
I think this means because usually when you deliver denture and the last slip you deliver with denture hydrated, if the denture comes in not hydrated for at least 3 days or 72 hours, you can do it quickly by put it in the pressure pot and hydrate the denture at before you deliver. Yeah.
Thanks for that, Quinn. This is the last question that we got. So which muscles are activated when having patient push tongue against the thumb during border molding? I don't know, dude. I don't know. I forgot anatomy. I don't know, transverse muscles. I'm not sure, honestly.
For that one too, I don't think it's as much the muscle, but you just want to make sure that when you actually have the final denture and it's in the mouth, you want to make sure that when the patient pushes their tongue forward, it's not going to cause the denture to tip out. And so if you account for that while you're doing the border molding, then you'll make sure you don't overextend it. I think that's the main reason you push forward.
Yeah.
Just make sure you don't really extend it too much.
Yeah, so when the patient brings the tongue forward, you're border molding the lingual frenum area right here, right? So making sure that that area is captured at a functional border. Yeah, so just in general, based on my memory, which is really bad, we had a lot of sequencing related questions, like steps of an appointment in order. And I remember having to write them down in order. So those questions might come up again. So I would know the sequence. I think that's a very important thing to know for this exam. Select the pressure technique, definitely know that. That's the impression technique you use for the final impression. and the occlusal plane definition from the maxillary incisal edge position to the junction of the mesial middle and the distal 1/3 of the retromolar pad. Yeah, what else is important?
Can you go over the selective pressure technique?
So for the selective pressure techniques, you place pressure mostly on the primary support area, and then the one that on the vestibule, they are at rest. They don't really put a lot of pressure on that areas. You guys can go back to the slide where they have functional impression techniques where you have the patients wear the dentures. So that's also when I address the lack of retentions at the dentures. So when you fix the dentures with viscogel and then let the patients wear for 2 or 3 days, you're actually doing a functional impression techniques. You let the patient wear the dentures with viscogel. So when they functions, it marks on the viscogel. So then you send the dentures with the viscogel that is already function, right? For a lab relines, that is the functional impression techniques. So like the pressure techniques is when you make your custom tray and you adapt the primary denture stress varying areas very well. Like when you make your custom tray, you put pressure on top of the ridge and then the buccal shelf, for example, in the mandible. So they adapt really well to your to the soft tissues and the anatomy of the area. Those area where you border molding, it's non-bearing areas. So soft tissues with the muscle movement, they are more selective, but you border mold and then you take the impressions with that. So more selective pressure. So you put pressure mostly on the primary support, and then the area where you have non-bearing area, you do the border molding. I don't know if it makes sense.
Thank you.
Can anyone tell me the primary support areas for maxilla and mandible?
Is that primary support? Yeah, well, are we closing them? Anyone know? Okay, so what is the primary support for the maxillary? No one answer.
You have
Okay.
stuff in the chat.
Of the alveolar ridge and the palate, those are primary support of your maxillary. The mandible is the retromolar pads and the buccal shelves.
Yep. So it's more of like, I think the posterior aspect of the posterior lateral aspect of the ridge for maxilla. The anterior ridge resorbs very easily. So anterior ridge is not primary support. This is palate and the posterior lateral aspect of the ridge for maxilla, buccal shelf, and the retromolar pad for the mandible. So when you take impression, more pressure should be applied towards those areas versus other areas. So we've gone through all the list of questions. If anyone else has any questions, please let us know. You can shout it out or something.
I had a question. I put it in the chat because my mic is kind of bad, but it was about phonetics and how they're addressed during delivery. Like, for instance, I mean, the patient that we had, fortunately, they didn't have any phonetic issues. I just didn't know in the future how we would deal with that.
So when phonetics not correct, if you are your CR is not correct. Usually when they have the whisper, the space over at the your corner of the mouth. So I think best way to address that is to remake your dentures. But if they are in too much, then you can reduce the teeth. Yeah.
You said it was a problem with CR, but if they're overclosed, isn't that a problem with OVD?
Yeah, usually when you try in, that's the way to address if you are as correct CR. As correct CR and as correct video. So when you checked the patient at rest, right, you do CR by getting the patients to calm down at rest, and then you let them swallow and you put them in CR, and then you have them pronounce the F and S and the S sounds.
Yeah, sorry, didn't see the chat until now. So someone asked the question, can you explain why we soak the dentures for 72 hours in water prior to delivery? I believe that's to just keep the denture from distorting. I think when the acrylic is too dry for a very long time, I think it starts to lose its shape and could potentially distort over time. I think that's why. Yeah, is that right?
Could you explain H in Hanayo's formula, please? Or Hano?
Yeah, Hana's quint. I believe it was incisal edge on the top and.
Oh no, the H divided by 8 plus 12 equals L in the protrusive record.
Oh yeah, that's just to get the Bennett angle. So I think the Bennett angle is the resulting L. And the condylar inclination is the other variable.
So how do you determine H though?
So condylar inclination you determine through protrusive, you get a protrusive record, and then you put the record on the mounted cast on the articulator, loosen up the condyles on the articulator, and you gotta rotate it until it's like mechanically feels right, more natural, without a lot of force, more passive, and you lock it in that position, and that's the best condylar inclination.
Thank you.
Does lab make Facebook jig before or after? They make it before they process the denture, because after it's inaccurate. Lab remount shortens clinical amount, yeah. Not. So somebody asked, does lab remount shorten clinical remount time? I guess, yeah. If you don't control for vertical dimension ahead of time, I guess you'll be doing that on the clinical remounted casts. So I guess it does shorten the time of clinical remount. I love how some of the classmates are answering questions for other classmates. Can you explain the ideal tongue position for a patient? Why do we not want retracted tongue? Oh, so when the tongue is retruded, it tends to push on the lingual flange near the retromylohyoid area, instead of just kind of sitting on top of that concavity that you're going to create sort of on the cameo surface of the lingual flange. If it's retruded, there's less space more distally, and it easily just dislodges the denture. It's really hard not to dislodge the denture. So it's mostly like a retention or stability issue. Retruded tongue position, I don't know, it's hard to exactly describe what is considered, but you see a patient have the tongue relaxed, and you can probably notice that the tongue is a little bit more back. And maybe sometimes even more big too.
Make sure you guys know support stability and retention. Those are important. Like what is it resistant to? The direction of the force. Yeah, just make sure you get that slides down. And then for border molding from the lecture, from the lecture that I review, make sure you know the sequencing of border molding and the images. Make sure you look through the images, the landmarks, those are important. You might have to label, or yeah, they might have you just answer free type in, or they can have that as the multiple choice questions.
When
Questions?
I have a question. So when you're setting teeth, do you not do the excursives until after you have the protrusive record?
Yeah.
Okay, thanks.
Because you could do excursives, but if your protrusive record makes it so that your excursives that you got were entirely inaccurate, then you have to do it all over again. You're gonna end up adjusting excursives no matter what after the protrusive record is taken. But I know in real life, in private practice, real life, I know they tend to just do everything before and hope that it matches. And I think oftentimes it decently matches, so not like too much to fix. But in terms of like theoretically speaking, in terms of the sequence, that would make more sense to do excursives after only after the protrusive record. Any other question? None, nada. Okay, here's another question. What are we checking for extraorally during first appointment, like preliminary? Oh, Raquel, can you answer this question? I didn't review this lecture.
Yeah, so basically what you want to check for is like the overall facial aesthetic, so that you know like what to plan for your final denture. So you want to check like the facial midline, you want to check you know, if they have existing dentures, you definitely also want to look at those beforehand. So like see the size, the shape, the color, the smile line, all of those things. So you want to do all of that during the first appointment. And that's really the only time where, I mean, you could also do it at later appointments too, you know, when you're doing teeth selection, but you kind of want to get a general sense of like what the person's like facial anatomy is like. And of course, you also want to check for any type of like oral diseases. Mostly those are intraoral. So like any types of sores, especially from like an old ill-fitting denture. But I mean, if they have any other like weird like skin lesions, you can also look for that at the beginning.
Yeah, it's basically like a pre-TP. I guess you guys don't know what a pre-TP is, but basically you're just gathering information. Because all you're doing is taking alginate impressions. So why not use some more time to just gather as much of the other information that you can? I don't know, ridge relationship, extraoral, facial profile, previous dentures, patient's concerns, all those things. Yeah. Anyone else? Okay, well, going once. Going twice. Going thrice. All right. So that's it. Hope it helped. Yeah, well, great. Good luck, everyone, on the exam. Yeah, just be sure to know sequencing pretty well, selective pressure technique, and the remounts, and the what else? The occlusive plane definition and things like that. All right, everyone will do well. This test is not as bad as Chinese test, so that's at least a small encouraging thing about this test. Okay, well, thank you, everyone. Bye-bye. Good luck.